Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Niraj Kalore from Virginia, United States. Dr. Kalore is the Associate Professor of Orthopedics at the Virginia Commonwealth University Health System with interest in joint reconstruction and sports medicine. After completing his residency in Mumbai, Dr. Kalore pursued his adult reconstruction fellowship at the University of Minnesota Medical School in Minneapolis and a sports medicine fellowship at the American Sports Medicine Institute in Birmingham, Alabama, United States. Dr. Kalore serves on the editorial board of Orthoscopy and also is a social media editorial board for the ARCUS and the ANA, and is also a reviewer for several leading journals. He holds a US patent for automated hip analysis methods and devices, which he filed last year. He has published widely in the journals of arthroscopy and arthroplasty and also won several awards, including the Best Poster Award at the AOS annual meeting, and has also presented several papers at the ARCUS and the ANA meetings. So today, it's my great honor to bring back Dr. Kalore for this wonderful live program. Over to you,
Thank,
Niraj.
thank you, Dr. Gopalan, and welcome everybody to this session on technology and total hip arthroplasty. Today, we'll be talking about why is technology needed in hip replacement and what technologies are currently in use and how each one of them work and what are the pros and cons of each one of them. So first of all, we need to understand some of these total hip replacement paradigms to understand why we need technology in total hip replacement. So the first and the foremost paradigm of a hip replacement is to restore the hip biomechanics. This breaks down into leg length, offset, and the version. Now, leg length discrepancy after surgery is the commonest reason for getting a malpractice suit in orthopedics. So that is something really very important. Sometimes appears simple, but can become problematic. So if there is a quantitative way of measuring leg length, that can be very helpful. It is easier to get an assessment of leg length when you're in supine position, like you're doing an anterior hip compared to when you're in a lateral position. So that factor also comes into play. Similarly, offset restoration is important for hip stability. The next one is version, which is very important for hip stability. Out of the different measurements that we can manually make, version is the hardest to make, hardest to assess by the human eye, and that's where the maximum errors happen. Now, the version can be femoral or acetabular or combined version. The femoral version varies a little bit, but it's mostly controlled by the anatomy of the femur once you have a properly sized stem. So there is not too much variation in it. Compare that to the acetabular version. It's basically a hemispheric socket. You can literally change it as much as you want. So there's a lot of room for error, and that's where most of the errors happen in hip implantation is acetabular version, and also happens same with inclination as well. So all of these can be quantifiably measured and optimized with the help of technology. The other paradigm of hip replacement is to avoid impingement with range of motion. Now, in manual testing, we test it with the patient in one fixed position, supine or lateral, and look for component impingement as well as soft tissue or bone-to-bone impingement, and try to minimize that in surgery. That was the concept, let's say, 5-10 years back, and it's still valid, but it has become more complicated because of this new highlight of the hip spine relationship, which basically says that a cup that is covering the head ball very well in a supine or in a standing position may not do so when you are in like a sitting position or in a squatting position. Uh, that's one. And the second part of that is that the lumbar spine mobility is important in providing adequate coverage of the femoral head during these sit to stand motions. So people who have stiff spines, like who have lumbar spondylosis or lumbar fusion, initially it was only for like people who have like a lumbosacral fusion, they can't have this mobility. which is probably an extreme case. But over time, we have come to realize that people who have degenerative lumbar spine pathology, which is not too uncommon in people getting hip replacements, they also have some of these hip spine issues. So it is getting more recognition that we need to be able to do some kind of dynamic testing, or at least some kind of simulation, maybe during surgery or before, so we know for sure that we'll have adequate head ball coverage in throughout the functional range of activities for that particular patient. So this kind of takes the hip replacements in a more patient specific direction, which is harder to assess manually, and that's where technology comes into play. So technology would help us to reliably restore these multiple variables that we looked at, and give us intraoperative feedback which is quantifiable and actionable, and that way we can optimize our hip replacement surgeries. So that goes for explaining why we need technology for total hip replacement. Even though this is so, technology is not so widely used in hip replacement compared to knee replacement. And this graph shows that. This is from the 2020 issue of the Orthopaedic Research Network. What it says is, from this sample of joint replacements, about 10 to 13% of total knee replacements use some kind of digital assistance during surgery, whereas for hip replacement, the number was only 2%. And there was no difference between year to year between 2018 to 19. So technology hasn't really gotten as much traction in hip replacement as it has gotten in knee replacements. This is the current technology utilization for hip replacements. This is basically dominated by two things. One is either use of a semi-active robot, or the use of a custom implant and custom cutting guide. Those are really the technologies that are widely used, though there are several available, and we'll discuss each one of them as we go along. For the sake of understanding the technologies that provide guidance, uh, these are either navigation based, or they have custom cutting guides that have been made. So you can use that to translate your preoperative plan into your actual surgical variables. The navigation most commonly is optical navigation, which uses infrared spectroscopy. That's what is in most common use. Everything else is on the sidelines, but it's upcoming. Electromagnetic navigation, that's another variation. Ultrasonic variation, navigation. Mechanical navigation is an interesting one. And so also the gyroscopic or accelerometer based navigation. In terms of actually helping the execution of surgery, these guidance systems do not help with that. But the assistance systems like a haptic or a semi-active robot does help with positioning the guides and making sure that you do not cross the haptic boundaries, so that your cuts are more precise. There is another breed that has come up, which is an active robot. Actually, it's not a new thing that has come up. Historically, there was this thing called the Robodock, which is now in the Smithsonian Museum. It was added to the museum back in the 1990s. So this thing has been around for a while, and it still hasn't become uh, a mainstream device. So there are some issues with that, and we'll discuss as we go there. So the computer navigation, uh, there are multiple components of this. The key component is how you track the motion, or how you track the bone movements. Most commonly, like I said, is the optical navigation, is the name given for infrared spectroscopic navigation, where infrared light is limited from a source which is outside of the field. It is reflected from reflective spheres within the field placed on bony landmarks or on a probe, and it is captured by a camera which is again outside the field. That's the commonest way for tracking in navigation. The next aspect of this is these can either be image based or can be imageless. The image based, they require a preoperative CT scan, which is currently the gold standard, said to be the most accurate for preoperative planning as well as for translating the plan into actual surgery. Fluoroscopic navigation is a very interesting and a new development, and we'll discuss it as it comes. I haven't given much details on ultrasonic navigation in the following slides because it's still upcoming. But the idea is that in obese patients, or when you have difficult exposures, let's say because of revision surgery or whatever, you may not be able to palpate the bony landmarks as well. For those situations, an ultrasonic device can help identify those landmarks. Again, for every ultrasonic application, the expertise of the user becomes important. So there are variations and there are difficulties in applying that in keeping sterile probes and such. So again, it has not caught the mainstream attention so far. The imageless navigation has been talked about a lot because it eliminates a preoperative CT scan. Some of this is based on insurance needs, like the insurance not wanting to pay for a CT scan or a 3D scan before surgery. For whatever reason, this thing has gotten a lot of attention and a lot of publications on imageless navigation. So let's talk a little bit about this uh, imageless navigation. So even though I have used the CT scan here to illustrate, in an imageless navigation, there is no preoperative CT scan, there is no intraoperative imaging. This relies on identification of the anterior superior iliac spine and the pubic symphysis on both sides, and measurement or simulation of this anterior pelvic plane. And this is where we are manually identifying these landmarks where there can be errors. And because there is no preoperative map, there is no, but of course it eliminates the cost of a preoperative CT, eliminates the radiation. So it is still in favor. The next variety is an image guided navigation, where you are doing a preoperative CT scan, using it to size your components, using it to see how exactly they should be placed, what sizes and orientation is appropriate for it. The preoperative CT scan is used to prepare a 3D model. This computer model can be used to quantify your registration errors, and that way the registration error can be controlled. So in general, if an error can be quantified, then it can be controlled and corrected. If you cannot measure it, it is very difficult to correct it and hard to know if you really corrected it or not. Now, how does this navigation work? I have touched on this briefly before, but basically infrared source outside of the field emits the infrared radiation, which is reflected off of these spheres present on the, in this case, the reamer handle, and also on a bony landmarks. Usually a 3-sphere array is attached. To the bone, it is attached through pins. And this signal is captured by a camera outside, and then the computer creates the model based on that feedback. The main advantage of this is that gives real-time feedback on cup position. And that's where it can reduce the outliers in version as well as inclination and make it more reproducible. The downside, there are multiple. Of course, the cost issue is there. Plus, you are putting pins in bone at different sites. It can cause some stress risers, and you can bone graft it, like Dr. Gopalan said on the last time we talked about it. But that is an issue. You can also get infections. Also, the line of sight issue. What that is between the reflecting spheres and the camera, as well as between the reflecting sphere and the source of the infrared light, you can't have any obstruction. So if you have obstruction, that's going to cause error. and we are looking at directly in the surgical field, so you had to constantly kind of move around, make sure you are not getting in the field of the camera, and that's a headache. This does add more operative time because you are putting the pins, you are doing the bone registration, you are doing the kinematic registration, moving the hip around, finding the center of hip. So all this adds up time to about, in literature, it's about 18 to 20 minutes. This is not applicable in every cases. So some cases there may be soft tissue constraints like significant obesity and stuff, or revision surgery, scarring. For whatever reason, soft tissue constraints is one of the commonest reason why navigation has to be abandoned. Also, it has been reported that it had to be abandoned for excessive pelvic tilt and unreliable registration or significant errors in registration. So it's not universally applicable, which also means in some of the most difficult cases, this thing you may rely on but may not really translate into actual effect. Besides that, even if you use it, uh, it doesn't really translate into functional improvement for the patient. In other words, if you do a manual hip replacement and you do a computer navigated hip replacement, the patients are not going to have much difference in function. And that's kind of a theme in most of these technology applications. Briefly about electromagnetic navigation, not in common use, was like an alternative to the optical navigation, where it uses electromagnetic field to do the tracking. But the problem is the power instruments that we use, they interfere with the electromagnetic field, limiting its utility. This is kind of an interesting one, which is I would say a next generation of optical navigation, where instead of the camera and the source of infrared light being outside the field, this is placed inside the field on the iliac wing with two pins. Uh, and the rest of the mechanism is similar. This is cleared for total hip replacement used at this time. It does have line of sight issues, but the line of sight is within the field. So assistant standing across or all the way around is not going to bother it. So that's an advance. The benefits of this, that even though this is smaller and doesn't have the line of sight issues, it still gives accuracy for cup position that's comparable to the full scale navigation, which is a really important thing. This, however, does not give you any feedback on component sizes. And that's in general too for all navigation. They truly don't give sizes other than if you are using fluoroscopic navigation. Then we come to this newer navigation. New in the sense is kind of branded new, but for ages we have done this. We have a difficult hip and not sure about things, get an x-ray and take a look at it, and based on that kind of assess your leg length, offset, and in some way get an idea about the cup version. So that's not entirely new, but the use of a software for trialing during surgery, that is new. And I think it's kind of improvement over the old x-ray technique. So here we are basically not depending on any type of preoperative CT scan. We are templating the hip on regular x-rays. During surgery, we apply fluoroscopy. Uh, we place the trials based on our templating, and then again use fluoroscopy, and the software actually can tell you the leg length difference and the offset. In addition to that, based on how is the opening of the cup, it can also quantify what version the cup is in. So that intraoperative feedback can be used. In addition to that, the software lets you experiment with different leg lengths, different offsets, and gives you idea about what your hip biomechanics is going to end up being. There are additional variations that allow you to test, or not test, simulate range of motion, which is kind of important for those patients with stiff spines, because you can simulate a sitting position and see how the impingement would be in that position, how much of uncoverage you have. So in that way, in my mind, this technology steps ahead of the rest of the navigation. The other thing is fluoroscopy is widely available. Most ORs, almost every OR here in the US has fluoroscopy, and most big ORs in most countries should have it. Uh, and there is no need for preoperative CT scan. You are not uh, locating landmarks with a probe. You are not registering bone. You are not tracking. So all these things are not there. We're not putting pins, so the other issues are not there. Additionally, because it gives you feedback on how the hip would be with a different length, different offset, it reduces trialing and consequently may reduce the OR time as well. And additionally, like I mentioned, for stiff spines, it has simulated motion, which can be of benefit. The downside is that there is radiation exposure, there is fluoroscopy time. Sometimes there can be contamination issues because of the fluoroscopic arm if it's not properly draped. But overall, this one is my favorite because it's existing technology that is being modified to give intraoperative feedback on a variety of issues. Now, any of the other ones are not going to give you idea about the screw safety, like did you put the screw inside the pelvis? This can directly show you that. It can also show you if you crack the femur, if you ream too deep, if you did not ream adequately. So all these issues can be directly seen. So I really like this one. Now, this is an interesting one. This is a mechanical alignment tool. So patients have a preoperative CT scan that is used to measure the optimal version of the cup and the optimal inclination and how it should be based on the patient's anatomy. There is this sterilizable protractor basically, uh, where based on the pre-op plan, you would have the exact numbers on what inclination and what version is suitable for that patient. You would put pins in the pelvis, in the iliac wing, the ischial wing, and I think close to the pubis. So those three pins are put in, and then you dial in the version based on the preoperative plan, and you can attach a guide to it and place your reamer handle as well as the cup impaction handle parallel to that rod. And that way you have a clever way to reliably produce inclination and version. There are some additions have been made to it where you can additionally measure leg length and offset. So at this time, this simple technique can actually give you leg length, offset, cup inclination, cup version, but no feedback on sizes. Uh, this is of course faster than CT-based navigation by nearly 20 minutes. Accuracy is comparable to CT-based navigation in some studies, but it does require a preoperative CT scan. It does not have as many pin site issues, but it does have some pin site issues. This is another variation of navigation based on an accelerometer or a gyroscope, uh, which is mounted on pins placed in the iliac wing. Then there is a metal marker on the trochanter, uh, and you use a laser pointer in the unit to locate the distal femur as well as the second metatarsal. So that way it gets the registration. So this does involve pin placement, does involve registration, and then it gives an intraoperative assessment of cup position, leg length, and offset. The benefit is there's no preoperative imaging. There are no line of sight issues. The accuracy is comparable to full navigation for cup position. The accelerometer is disposable. I think the battery unit is not, but the actual accelerometer is disposable. So you have to buy it for each case, which is a cost. Again, it doesn't give cup size, bone integrity, stem size, or position. So in some ways, it is limited. The next one is patient-specific instruments and implants. For this, patients get a preoperative CT scan that is used for making models, which are patient-specific. These guides are manufactured that you will fit based on the bone contours during surgery, and those you will use to make the cuts and do the reaming. And based on that, you can implant your components in a more precise way as claimed by the manufacturer. So it gives fixed guidance. This is not live guidance. So if something goes wrong during surgery, you, unless you are using additional navigation, you don't exactly know what is happening. You may know that it's wrong. You don't know exactly how wrong it is. This does make the inventory lighter because you don't need to carry so many instruments, because all the cutting blocks are already coming in a sterile pack. You only have one cutting block for one cut, or maybe two blocks for one cut, something like that. uh, the manufacturers claim that there is improved accuracy on cup position, leg length, and offset. This, however, has not translated into real life so much. Patient function hasn't been much different. The cost is very high. So these are the limitations of this technology. Coming to the probably the most advanced application of robotics in hip replacement. This is a fully active robot. This is a version of the Robodock that I was talking about earlier. The Robodock was made in collaboration with IBM engineers back, and it became part of the Smithsonian Museum in the 1990s. But there have been some issues with that technology. So this is the most current iteration of it. I think this has come out for the knee. It has been approved for the hip, but is not out yet. But I could be wrong. Maybe it is. Uh, so this involves a preoperative planning based on a CT scan. This is a 5-axis robotic arm. It uses bone milling at the end, and that's where one of the problems is some people say this can get as high as 176 Fahrenheit. So really have to be careful not to cause bone necrosis. Uh, but the bone milling can be very precise because it's robotic controlled. It also helps with the cup implantation. The surgeon basically is supervising here, just looking at the robot and having an emergency control shut off valve, shut off switch in his hand in case something goes wrong, and of course irrigating. So it's kind of annoying. But it gives comprehensive feedback on implant size, position, leg length, offset. It is known to reduce outliers and improve the reproducibility in cup inclination, version, leg length, and offset restoration. However, despite all of this, there is no change in patient function. This has very, very high cost. This is probably the most expensive robot. Of course, a preoperative CT scan is needed. Earlier studies had reported abductor damage, heterotopic ossification, increased risk of dislocation, femoral fractures. There were a lot of lawsuits when this thing came out. So it's still not in widespread use. And that's like 30 years since it came out. So the current leader in technology are these semi-active robots, where the robot actually positions the guide or the reamer for you and you do the surgery. So in a way, the liability is with the surgeon. Uh, it does require a preoperative CT-based planning. It's a very comprehensive, detailed planning. There is use of navigation. So this is a combination of preoperative CT, intraoperative navigation, as well as the robotic arm. The robotic arm has a thing called the haptic controlled cone or an area, where if you look here, right here, this blue cone, that is the haptic cone on exactly where and how deep the reamer can go. If the reamer tends to deviate from it, the arm is going to get stiff and not let you deviate. So that's the way for the haptic. It gives you feedback, gives auditory feedback, gives a manual feedback where it kind of vibrates. So that's the haptic feedback the surgeons get. It basically controls and makes sure that your acetabular reaming and cup impaction is appropriate. and gives feedback on implant size, position, leg length, offset, reduces outliers and increases reproducibility in cup inclination and version, leg length and offset restoration. Again, no change in patient function has been proven in randomized controlled trials. Cost is high. A pre-op CT scan is needed. Multiple pins need to be placed for the navigation. So again, pin site issues are there. It changes your workflow, that is true. It increases your operative time between 20-25 minutes. So that also is an additional cost. This is something that's upcoming. And sorry, I couldn't remove the name. But this is a small table mounted robot that is said to be lower cost. It has 5 to 6 arms. The company that's coming out with it, they want it to be used for multiple applications, not just orthopedics, but other applications as well. So in a way, this is also a soft tissue robot. But the robotic arm will basically position the guides for you. There are no pins, and so the pin set issues are not there, but it will basically position the guide for you. This will be mounted on the OR table. This is a smaller footprint. Uh, and of course, there are no studies right now to see what it will exactly do. And it's still pending clearance, probably coming out this year. So summary, new technology helps reduce outliers in component position. The functional benefits to the patient of this new technology are not proven. Fluoroscopic navigation, at least to me, appears most comprehensive and most practical at this time. The semi-active robots are the most commonly used technology in hip replacement at this time. And that's it from my side.
Thank you, Niraj. Yet another fantastic presentation from your side and really cutting edge. You've really looked into all the cutting edge part of total hip replacement. Just a few questions. Uh, do you use the EOS software or is it common in the US? For example, patients with spine pathology, ankylosing spondylitis, to get the version of the acetabulum is quite difficult, right? So there's some interest in the EOS software, isn't it?
Currently, we do not have the EOS software in my place, but multiple other centers do have it. And I think that is something that is an upcoming part to investigate and quantify the hip spine relationship. Right now, all we are doing is standing and sitting radiographs and doing manual measurements based on it.
And do you think there's a role for, technologies like artificial intelligence, etc., for hip replacement? Because there has been some interest in identifying. I mean, when we just talk about new technology, identifying. Suppose you have an hip implanted somewhere, and he's coming for revision to you, and you get the X-ray and put it onto some artificial intelligence-enabled software, and you get what is the implant.
Yeah, I mean, that is interesting. And I think there are some applications. In this case, we don't really have to buy the application. What I do is I just ask the rep. I have very experienced reps. They also have a software that they own and the company owns that can identify that.
Okay, thank you for that. So what do you think about the cost as well as the operating time in these, new technologies, the CAS, the robotics? It's all the same. Like it's the same as in total hip, isn't it? I mean, total knee.
Yeah, it's
It's
exactly like that. It's exactly like that where most of these studies, if you look at it, their outcome variable is how many times is the cup out of that safety zone. They don't see if the patient function is different, or if they try to, they can't find the difference. So it has been a big challenge for technology to make a difference in function. And I think it will happen earlier in total knees and later in total hips, because the rate of satisfaction for total hips is so high. It's really hard to beat that. But the thing is, with all the other advances, everything else has literally been done. So I mean, the rapid recovery, yes, that's one more thing that's happening now. But other than that, most of the avenues for advancement have been kind of explored. And that's why I think most of these companies are putting their R&D money in technology.
Okay, thank you, Neeraj, for that. The other question is, see, the bigger issue, the number of complications are slightly higher in a total hip replacement, isn't it? If you look at dislocations, slightly
Yes.
higher when you compare with knee, because knee is a much more safer and reliable surgery. So, do you think that the cup positioning is, I mean, the technology should really look for that, and that is where new technology should focus on? Because still in your data, I mean, the data you presented, more technological advances happen more in the knee rather than the hip. Don't you think the hip is more important?
The hip is definitely more important in some ways that it has. So the hip has this thing where if you go out of a certain limit, then it suddenly becomes so bad it's just going to dislocate. But the premise is that the surgeon should be able to identify that thing. Like when I do a simple manual hip replacement, I put it through so much testing and I change so much. I spend like 20-30 minutes just making sure that it's stable enough. And I mean, if I am in doubt, I get an X-ray and I get enough information that most of these things can give. So it's hard to beat that. So I still think even though the hips are important, they are lower in number compared to knees. That's probably different over there.
Yeah, I mean, different
Prob-
demographics, exactly.
Probably different.
And out of the technologies, new ones that you mentioned, what is the one that you use or would you like to prefer in your OR?
So we have the Wellis navigation that is ready for use this year, and the robot, the small robot, would come this year as well.
The
So
Mako.
it's interesting. Not the Mako actually, is the Wellis, the smaller robot from J&J. That's the one that one of the hospitals is getting. Also, the thing is, different hospitals have different robots. So the local HCA hospital, they have the Mako robot. The another hospital that has the Depu robot that's coming out. And the main VCU, they don't believe in robots. This is just
Okay,
get an X-ray.
pretty interesting. Anyway, thank you, Neeraj. I think that's all the questions that we have for the session. Fantastic talk. I mean, both of your sessions were really good. I mean, a lot of new insight, and I'm sure this is going to help a lot of people all over the world. Thank you very much for joining in.
Thank you.